Good afternoon to everyone. I would like to discuss about rehabilitation of speech and swallowing in head neck cancer. Head neck cancer and treatments are very challenging for patient as well as professionals. The treatment includes surgery, radiation, as well as chemoradiation. The incidence of dysphagia at the time of diagnosis is almost 40%. So speech and swallowing problems are the most challenging functional deficits for head neck cancer due to its treatment as well as treatment effects. So swallowing disorder, dysphagia in head neck cancer is one of the significant symptoms as well as morbidity. The severity of the dysphagia depends upon location, size, and impact of critical nerves and structures. The dysphagia can be broadly classified into two types: surgical-related dysphagia and non-surgical-related dysphagia. Non-surgical, again, we need to think about acute toxicities as well as long-term toxicities. So my focus area will be oral carcinomas, salivary gland tumors, nasopharyngeal carcinomas, laryngeal carcinomas, hypopharyngeal carcinomas. So we all know the swallowing has three stages: oral stage, pharyngeal stage, and esophageal stage. What are the pathophysiology of swallowing due to surgical? It can be a carcinoma of lip, can be inadequate lip seal can happen, and it can be a carcinoma of buccal mucosa, lateral defect. They have to remove the segmental mandible, and lateral defect can happen, unable to able to chew very well. And if it is a carcinoma of tongue, they cannot be able to propel the bolus very well. These are the surgical related oral dysphagia can happen. And what are the non-surgical related oral dysphagias? Can be due to radiotherapy. They can have a lot of edema, fibrosis, and epiglottis may not move after a radiation therapy. And patient have aspiration, can be due to laryngeal aspiration or spillage through piriform sinus. And all these patients will have difficulty in aspiration, have dysphagia, and that leads to aspiration, and aspiration has a lot of potential complication, can lead to even death also. So we need to understand the signs and symptoms of dysphagia. So patient come with the complaining of nasal regurgitation, loss of weight, unable to swallow very well, and also he will say that he can cough is happening after swallowing. These are one of the signs and symptoms, and we need to be very careful to evaluate these patients. So how are we going to evaluate? So moving on to the recovery of swallowing function after oral cancer. Definitely after oral cancer, surgical treatment, one of the very good modality for the treatment. So the treatment phases can be broadly classified into four types as per by Katrina Bleeth. So initial phase, immediately after following surgery, wound healing commences and swelling will be present. And here, gradually we need to introduce the swallowing therapy. And later, patient will go back to his hometown and again come back to follow up. And again, we have to evaluate this serially, and we need to optimize the swallowing function and evaluation. And next thing, patient will be waiting for adjuvant radiation therapy. And that point of time also, swallowing evaluation and therapy is very, very essential. And not only speech language therapy, dietitian also very, very essential to optimize the function. So how are you going to evaluate swallowing function? Definitely clinical swallowing evaluation is a must, and we need to examine the oral cavity, and we need to do the small water swallow test, and we need to evaluate how the patient is swallowing. And if it is a high risk, we can start with modified water swallow test. If it is low risk, then we can gradually start with 100 ml water swallow test and see how the patient is swallowing. And when are we going to start swallowing therapy for after surgery? Definitely 5 to 7 days is very good to start swallowing therapy after oral carcinomas. And if it is extensive tumor with very advanced reconstruction, those patients will require some time for rehabilitation. So this gentleman, carcinoma of right buccal mucosa, underwent segmental mandibulectomy with neck dissection with petricularis major myocutaneous flap. The patient is good and he is doing very well, good mouth opening. We'll say how he is swallowing. So this is a simple water swallow test that can be evaluated through clinic, and the patient using his fingers to occlude his mouth to reduce his drooling. This is how he is managing taking liquids, but small amount of drooling is happening. This we cannot be able to improve further by swallowing therapy. Definitely reconstructive surgeons are very, very essential. If this is persisting, then they may have to do a minor secondary surgery to optimize his function to reduce the drooling. This gentleman, carcinoma of buccal mucosa, underwent small marginal mandibulectomy with thoracodorsal artery perforator flap. Immediately after surgery, he visited swallowing therapy. You can see his mouth opening, maybe 1 or 1.5 fingers. Tongue range of motion is good. And this gentleman, he did not have any feeding tube. Even immediately after surgery, we removed the feeding tube, and he was following up continuously during radiation therapy as well as radiation therapy. This is how, immediately after radiation therapy, the only challenge is trismus he was having, in spite of doing all range of motion exercises and everything. This is the only issues. Swallowing wise, he can able to take liquids and soft food consistencies. So this gentleman, carcinoma of anterior one-third lower alveolus, underwent segmental mandibulectomy with free fibula osteocutaneous flap. The patient is good. It's a very extensive tumor. It takes time, not like other patients. Feeding tube is necessary immediately after surgery, and we have to evaluate. And we need to think about whether we can able to initiate orally or not. If it is, we can able to initiate, then we need to think about what type of food consistency we can able to initiate. We can able to initiate whether liquids or thick liquids or soft food consistencies, and we need to explain about the radiation toxicities also if the patient is having any adjuvant therapy, and we need to follow up weekly during radiation therapy. And after radiation therapy, at least 3 to 4 weeks, we have to call the patient and see how he is performing. And we need to think about whether we can remove the feeding tube after 4 to 6 weeks. If possible, definitely we have to remove the feeding tube. That will improve his quality of life as well as swallowing function. So moving on to the swallowing rehabilitation in tongue carcinoma, it depends upon the site of the tongue, whereas it is anterior tongue, it is entire tongue, or hemi-tongue, where the patient is having problem. If it is a posterior tongue, definitely those patients may go for concurrent chemoradiation. If it is anterior tongue, definitely surgery is the first option. So this gentleman, small tongue, anterior tongue, underwent wide excision with radial forearm free flap. Mouth opening is good. The only problem he is having is little amount of speech disturbances. Otherwise, he is doing well. He is doing his routine work, and he is following up regularly. But how we can able? Is it possible? Whether clinical evaluation is enough? No, we can't stop with clinical evaluation. In few patients, definitely we have to use some kind of instrumental swallowing evaluation. That where comes endoscopy or videophoroscopy. Sometimes we cannot be able to identify if the patient is aspirating or not. So videophoroscopy, definitely we can jointly done in radiology units and see how the patient is performing. Is there any, what is the cause of the aspiration? That we need to find out in few advanced carcinoma patients. Otherwise, we can do the endoscopic swallowing procedures. Here, we don't need to take the patient to the videophoroscopy suite or any kind of radiological procedures. Just we have to insert the nasal scope through the transnasally and see how the patient is performing in terms of swallowing function. So here, definitely we can able to identify whether the patient is having aspiration, or is he safe for swallow, or if he is not safe for swallow. And if it is safe, in which consistency he is safe, all those things we can able to identify by using endoscopic swallowing evaluation. And this patient, carcinoma of total glossectomy, underwent 1 year before. It was very challenging to rehabilitate for him. He was having feeding tube as well as tracheostomy tube almost 1 year. After that, we did a videophoroscopy to see how the patient is function. He is good. He is able to swallow very well, but only liquid consistency is swallowing. There is no any kind of aspiration. After this procedure, we remove the feeding tube. These ideas we'll get from the videophoroscopy. So here, this gentleman, carcinoma of total laryngeal carcinoma, underwent total laryngectomy. He came immediately after surgery, almost 3 weeks after surgery. He came with a complaining of severe difficulty in swallowing. We performed a videophoroscopy. Okay, it's okay. I'll show at the end. So these are the surgical related dysphagias that we have managed. Moving out to non-surgical related dysphagia, this is majorly of organ preservation, like laryngeal carcinomas and hypopharyngeal carcinomas. Definitely pre-treatment swallowing evaluation is must before starting of radiation therapy, and we have to find out whether this patient's swallowing function is good and whether is he a potential candidate for organ preservation or not. If the pre-treatment function is very poor, he is not a right candidate for organ preservation, then he may have to go for total laryngectomy, definitely. And once the patient's swallowing function is good, definitely he has to be informed about the swallowing exercises, and we have to initiate swallowing exercises, and we have to follow up weekly those patients and see how the swallowing performance. Definitely, if there is a risk for aspiration, definitely we need to think about the feeding tube. And after completion of radiation therapy, definitely 3 to 4 weeks, we need to see when to start orally. If the patient is having feeding tube, definitely we need to think about whether right time to initiate orally and how this can be decisions can be taken by this can be taken by endoscopy as well. So post treatment after 3 months, definitely we have to evaluate these patients, and active surveillance is very, very essential to see the late dysphagias. Sometimes after 5 years, these patients have swallowing disturbances, and we need to find out all those things. So this gentleman, carcinoma pharynx, we'll see how he is swallowing. Yes, it's good. It is playing here. He's having severe aspiration. Here, video fluoroscopy, he's having severe aspiration. The next patient, carcinoma of right piriform sinus. You can see there is a severe growth. And card pulse is also there. And we have given thin liquids. We have asked the patient to swallow. It's a before commencing any treatment. And you can see there will be a massive aspiration will be there. So what is a successful pathway for dysphagia rehabilitation? Definitely, pre-treatment evaluation is a must. We have to examine the patient. We have to do the swallowing exercises, education of swallowing exercises. Then if we require video fluoroscopy or FEE is definitely very, very essential. We have to follow weekly. Then 3 months, 6 months, and 12 months is very, very must. Along with speech language therapy, dietitian is very, very essential to optimize the speech and swallowing function. So what are the strategies to improve swallowing function? Definitely exercises, use of nasogastric tube, and use of AMRT. These are very, very essential to optimize swallowing function in concurrent chemoradiation. Thank you so much.